officially welcome Senator Cassidy here. Senator Cassidy's a longtime friend and advocate for the entire LSU system, in particular our LSU Health Sciences Center here in Shreveport. So without taking a lot of the time, any more time, I'm real happy. I got to spend a little time with Bill last night, and he's 100% a friend. It was interesting, some of the questions that you guys asked, and I got to listen to that, and I'm glad. It was really neat. You got to remember, there were no less than a half a dozen physicians that signed the Declaration of Independence. This is not novel, but it has dropped off in the last 100 years. And now, thankfully, Louisiana has been in the lead with having physicians serve in Congress. And so I applaud what Senator Cassidy is doing, and we certainly need him as we forge forward in the future of health care nationally and in particular in Louisiana. Thank you, Bill, for being here.
Thank you, God.
So it's a great privilege to have Senator Cassidy here as a special lecturer for the microbiology and infectious disease course, and really to give us a glimpse about the question of how do we as a society address the big ticket items. And I've asked him to talk in an area of his own expertise clinically, which is hepatitis C, and things have been revolutionized in the past 10 years with drugs available to treat and actually cure hepatitis C with a huge price tag, about $100,000 per patient, up until just a few weeks ago when several new medications were approved at around $30,000 per patient. And so now we have opportunities to address curative therapies in hepatitis C, and the question is, who's going to pay for it? And that's a big question. Are we as a society willing to invest that money in payment? And Senator Cassidy, has been a friend since his time in the legislature here. I got to spend a flight from Atlanta to Washington right next to him one day, and this was probably 7 or 8 years ago. He may not even remember. And the whole time, all we talked about was his goals and aspirations for improving healthcare in our country. A long historic problem that he's been working on since he's been in politics. And so we applaud him for his efforts on our behalf as the state of Louisiana and also at the federal level. So, Senator Cassidy, thank you.
Thank you, John. Let's see if I have my laser. So this is my forward.
Use this one.
Got it.
And use the
got it. Got it. Hey, thank you all. Now, kind of as we were speaking beforehand, and when John gave me this opportunity to speak with you, my goal is to present an academic topic, but if you will, it is a very practical application of what we are learning, what you are learning, to a public policy plan. I'll say it for the third time because some of you came in late. But effective public policy is both a 30,000-foot view that has a knowledge of the granular. And you address the granular, but you have to do it from 30,000 feet. Now, I find that the folks who are most effective are willing to get into the weeds. You can't stay there because no one can follow you. This is a demonstration of something we are currently working on that I think would illustrate what of which I'm about to speak. Infectious diseases. And I'll start off very broadly, and then I'll come down to the particular. Okay, so by the way, there's a whole raft of issues related to infectious diseases right now. Antibiotic resistance. We have this latest, greatest drug, use it indiscriminately, and all of a sudden we have an even greater microbe which cannot be killed. You come up with a later, greater drug, you don't want to use it indiscriminately, how do you pay for it? Well, that's an interesting public policy plan, right? You normally pay for things by prescribing it to a lot of patients, but you don't want to prescribe it to a lot. You only want to prescribe it to a few, which means how do you pay for it? Secondly, emerging infections. We've seen Ebola, which is something we've known about for some time. We've seen Zika, which we've known about some time, but not with the sort of consequences that recent infections have had, as well as others. But how do you have an emergency response? This is so topical. It used to be, for those of you who remember Katrina, the response to Katrina, Congress had to appropriate money in the immediate aftermath of Hurricane Katrina. FEMA had to sit on its hands until Congress appropriated the money. If you notice, FEMA is already out in the field. What happened? Folks kind of did a autopsy of the response to Katrina and saw that one of the things that was a problem was the delayed response. And so Congress set up a fund. If there's a disaster, a special appropriation is not needed. Rather, the money is immediately there to take to the field to begin bringing relief to those who've been displaced. I've looked at that paradigm, and with Senator Schatz from Hawaii, we would like to set a similar emergency response fund for potential epidemics. While Congress debates whether or not there should be a fund to stop Zika from coming to the Gulf Coast, which with our warm, humid air had all the mosquitoes required to transmit Zika, what if there was an emergency response fund that, under certain criteria, the CDC could immediately begin to pay for spraying mosquitoes in Puerto Rico to keep that virus from coming to our shores? It shouldn't take an appropriation. What if you're on August recess? So we're trying to use the paradigm of FEMA for the paradigm of emerging infections. And lastly, where I'll dwell now, is the high cost of drugs. Now, the high cost of drugs is a problem of many aspects. So, but there's one, if I'll start here first, there's some in which you pay for a lot up front, think a cancer drug, that may prolong life for 6 months or 2 years. $100,000 a year, and you live for 6 months or 2 years. The other is a drug for a rare form of hypercholesterolemia, in which you're going to pay a lot of money for a long time. But there is a subset of drugs that you're going to pay a lot of money for, $300,000, $500,000, and then the benefit accrues thereafter. Think of gene therapy for cystic fibrosis, where you give it to the child, and she never, ever, ever, never has a complication of cystic fibrosis. We will save millions of dollars. Her life will be substantially better, but who's going to pay for it? Are you going to raise premiums by $1 million? That is not possible. By the way, we don't have answers to this. There is a drug coming along that is the problem with HIV as opposed to hepatitis C. Hepatitis C is relatively easy to cure because the virus does not integrate into the host genome. It always stays outside so it can be targeted and killed. HIV actually interpolates into the host genome. And so it's just there, and to destroy the HIV virus completely, the DNA or the RNA, you have to destroy the host genome. There is going to be a drug coming soon, I'm told, that will go to the host genome and snip out the HIV, pull it out and destroy it so that someone is truly cured of HIV. How much do you think it's going to cost? We don't know. But wouldn't it be great to never have to spend more money on very expensive HIV drugs, to have the risk of transmission to others and all the attendant expense thereof? So it's going to be an immediate, one-time, forever benefit. How do you pay for that lifetime cure? Now let's go to hepatitis C, which is, John mentioned, a specialty drug, which by definition, let's just say very expensive. And hepatitis C, the natural history of, has lots of expensive consequences. So, if you look at hepatitis C, and when I used to give this lecture, I would say that C stands for corpuscle, the Latin name, if you will, for a blood cell. It is spread by blood. And about 95% of those who are exposed will become chronic carriers. Of those who have hepatitis C, about 40 to 60% of folks will never have a symptom. But about 20% will have cirrhosis within 20 years of infection. And a subset will get liver cancer, again, the complications of cirrhosis, all very expensive to address. Now, we can treat it, but therapy, when it first came out, was $50,000 per person treated. And now, if you're at the VA, you get a special deal, it's only $25,000. That's a lot of money. It is a lot of money. How do you do it? There's something called value-based purchasing as one example of what you can do. In value-based purchasing, you only pay if the medicine works. But it turns out this medicine works 95+% of the time. So in this case, it's not as helpful. There are some who Bernie Sanders, for example, he speaks of marching in. If the federal government funded the Institute of Health, who then in turn funded part of the research that led to this cure, that the taxpayer can go to the company that produces this and says, hey, listen, taxpayer helped pay for it, we want it back. Give it to us. Give it to us right now. And we're going to distribute the medicine for free. And as attractive as that is, I think if it ever occurs, we will not ever have a cure for Alzheimer's or dementia or any of these other very difficult to treat illnesses that it's going to take a lot of folks motivated by the potential of profit to go out and find that cure. It is an ecosystem in which, again, very much a system of reward drives innovation. And I'm afraid if there was a chilling effect of this, we would never have these innovative drugs. So aside from being a big believer in property rights, I think just the long-term benefit of our country is that this is a bad approach. And then there is long-term financing. There's two ways to do it. There's one I call the mortgage model. We're going to buy a lot of drug, but we're going to pay you off over 30 years. Or the Netflix model. You folks know Netflix. In Netflix, you pay a subscription and you treat as many people as you can, as fast as you can. Kind of like watching every episode of Planet of the Apes over a weekend. And then there is a Netflix financing hybrid. You pay a subscription price, you treat everybody you possibly can, but then you finance it over a number of years. And so this is what we are currently discussing with our Department of Health and Hospitals and with some economists out of New York and Boston as to can we come up with a system that works. And as I tell them, this is important not just for the patients of Louisiana, although it's incredibly important for us, but it is also important because we have to find a system to pay for these cures too. So we're using this, if you will, as a way to begin to explore paying for those drugs with a lifetime of benefit, but a one-time immediate cost. So how do you do this? Well, first you got to recognize future. You got to do the business case. You got to do the business model. In medicine, we are used to, oh my gosh, cost is not a limit. We're going to spend whatever it takes. Those days are effectively over. We now have constrained resources where you're not going to drop $10 million on a single patient. You may do it occasionally. We as a society cannot do it for everyone. So, and it's hard to make a case for public policy by advocating that. So what we have done is put together a spreadsheet, and I'll show you in a second an example, using the epidemiologic and demographic data, the age, for example, related to those whom CDC tells us in Louisiana are most likely to be infected. Specifically looking at the Medicaid and incarcerated population, saying that those with private health insurance can kind of get it through their private health insurance. We then want to develop a model for the long-term expense of hepatitis C to Medicaid, and then find the most cost-effective way to treat and to finance. Now, it's fairly easy to say what is going to be a future savings. So, for example, we know that transplants, liver transplants, directly related to hep C, leading to cirrhosis and or to hepatocellular cancer, that the proportion we know from epidemiological data of hepatocellular cancer, HCC stands for hepatocellular cancer or liver cell cancer, this proportion remains constant. Stage 3 patients, not cirrhosis, which is stage 4, but stage 3, without treatment can progress, not always, but can progress to being chronic after 8 years. And lastly, when you look at the business case, newer drugs come off patent after 12 years, which means their price falls dramatically. So in your business model, you want to plan for what the price would be if you were treating over time, because the price falls dramatically. So we put up 3 examples. We call it the status quo case. Louisiana is currently treating about 324 patients a year. What does that do in terms of the progression of patients to cirrhosis, liver cancer, and liver transplant. The CMS, the Centers for Medicaid and Medicare Services, wants Louisiana to increase it. I think we have 1,500 here, but we actually modeled 1,000. What if we do what CMS tells us to do and increase that treatment level up threefold? And lastly, what I call the front-loaded, where we treat as many as possible. Now, this is very busy, but I'll walk it through, and I think it makes sense. What's our Louisiana population? How many on Medicaid? How many people with hepatitis C would be on Medicaid? How many would be eligible for treatment? We assume about 20% of folks just aren't eligible for whatever reason. How many of those will go to cirrhosis, cancer, be transplanted, and have chronic hep C, but not get cirrhosis, cancer, or need to be transplanted? What is the price per patient per year of a liver transplant, post-liver transplant, hepatitis C with cirrhosis, hep C without cirrhosis, and liver cancer? And then what is the cost of medications now, after it goes off patent, and then after it goes off patent for a couple of years, and can you get a discount? And then we have some additional costs that we decided not to include. This, you can make the spreadsheet. You log on to CDC, you log on to drugstore.com, and you figure out these numbers. It is not rocket science. It is just sitting there and thinking about it, and as you approach public policy, trying to have some granular understanding as well. So we talked about this, and this, and so how do we recognize future savings? Status quo, we said we're going to treat 324. Mandate here, we modeled 1,000, and then our front loaded, we said that we were going to treat about 8,700 per year, and these are just different ways of financing. And then we calculate, okay, if you treat everybody up front, that's fewer people getting liver cancer, needing transplant, or having cirrhosis, so therefore these numbers change. If you treat just a few every year, you're not paying as much on drug, but you have more complications. Whereas if you treat everybody really quickly, you have lots of drug cost up front, but long-term savings. And CMS, the 1,000 people a year, you have much higher drug cost, but you don't get the same prevention of long-term complications. Now, you can see, kind of to give it away, if this is your base case, if this is how much it's going to cost you over 20 years under our status quo model, to treat 1,000 people a year with the assumptions we have would cost the state of Louisiana roughly, what is that, $1 billion more? $950 million over 20 years? It's kind of like Goldilocks just wrong. You know, you're paying more for drug, but you're not treating enough people to really get the benefit of eradicating disease. So Goldilocks just wrong. On the other hand, if you front load treatment, you spend a heck of a lot more than drug. Well, here's your estimated first 4 years on drug, but you spend a heck of a lot more on drug, but look how much you save in direct medical cost over 20 years and annually. Now, you can only do this, really, practically speaking, is if you can finance this over time, so that instead of spending all this money for drug up front, instead you pay it off over time, in which case the annual amount you spent on drug is actually less than your status quo case. And so this is what our training as healthcare professionals can lead us to understand. Again, just to kind of further elaborate, 324 comparing to these, total cost over 20 years, and you can see Goldilocks just wrong. You're not treating enough to make a real dent in terms of long-term disease burden or complications, but you are paying a heck of a lot more for drug. And so this is the one which we are currently about to be operating under. I would say this is exactly the wrong one to operate under. And just to show you once more, kind of elaborate, first we have our numbers 1 through 20. And this is the number of liver transplants you would be projected to do every year. And by when somebody turns 65, the average age of a Hep C patient is, I think, roughly 53 or 54. So after 11, they roll off of Medicaid onto Medicare. So we're putting together a business model. We're only looking at Medicaid expense. We're not looking at societal expense. So they roll off, which is why you see these numbers flatten out instead of continually growing. Here's our cost per transplant right there. And then we do the same thing for cirrhosis, liver cancer, and chronic hepatitis C without it. At some point, all the folks who are infected are on Medicare, so they no longer generate expense there. And that gives you your total cost. Now, as I mentioned, this is the best. Now, I do the same analysis here. I won't go into detail. But you will see, if you front load treatment, you stop having people with cirrhosis. You stop having people with liver cancer. Because if you eradicate the hepatitis C, if they are stage 1 and 2, meaning early fibrosis, and you eradicate the virus, they never get to cirrhosis, which means they never develop the liver cancer, and which means that your need for liver transplant falls off. Now let me just pause for a second. As human beings, as healthcare professionals, this is what we want. If you had a patient, if it was your loved one, Jesus says to do unto others as you would have them do unto you. And that is echoed in every major religion. If we could do unto others as we would have them do unto you, if you had hepatitis C or if I had, and you were my doctor or I were yours, we would wish to be cured. We've got to make the business case. And it's one thing to be a physician and to say, oh my gosh, I want to treat everybody. Let me cure, let me heal. It's another to, as a public policy, to balance. If we spend everything on hepatitis C, we will have nothing left to support higher education. Nothing left to spend upon more research. Nothing left to spend on other needed medical services, for example, physical therapy. We may have to take money away from scholarship programs so that rising seniors cannot get the financial aid they need to go to the college of their choice. There are trade-offs across the board. So as easy as it is for us to say, oh gosh, we should just do this, it's the right thing to do. Is it the right thing to do if it deprives you from everything else? That question begs the answer, which is why you have to take your knowledge of epidemiology, of the average age of somebody, of the cost of drug, and build a business case as to why we should be doing something as a society. By the way, I'll mention once more. If you end up coming up to DC to do an internship with us, and those of you who came late, I gave an invitation to all the young folks in this room. If you'd like to come to DC and do an internship, we would love to have you. And this is the sort of thing we have you work on. We'd like you to be at least 21. That way, if you're arrested, you're on your own. But on the other hand, we do try and make it stimulating for you, and we try and make it meaningful. The intern that helped us with this, she will help shape how we respond to not just hepatitis C, but perhaps how we respond to that gene therapy for cystic fibrosis or that new drug for HIV. And so this is a way that we all pitch in for the betterment of our country. At the end, I'll mention once more that if you look at status quo, that if this is just kind of what it's going to cost if we do nothing, doing the CMS mandate is the worst. These are the best. But if you finance it, if you find an innovative way of financing and you can lower this annual cost, then you actually, that is the best of all. And this is practical because there is not much difference between that figure there and this figure here. And you could get a state legislature to agree to that because in a very near future, you're saving real money. So to conclude, one, let's just speak as healthcare professionals. If we front load the treatment of hepatitis C, we can save morbidity and mortality. Depending on the cost of drugs, we can actually save society money. But we need to find alternative ways to pay for these therapies as they enter the market. And all of this was enabled by the training you are receiving, and you may receive if you are so privileged as to join the ranks of one of these. And your challenges? There. That is you. Thanks for having me. Thank you, John.
Chairman of the radiology department.
No, I'm Cassidy. My mother-in-law makes the same mistake all the time. No, mother-in-law, I'm Cassidy, not Kennedy. I'm sorry, she didn't marry him. Thank you.
That the government is really focused in healthcare. You know, and unfortunately, I'm a little 3 times more the age of going and apply for your internship.
Oh, but we would still have you. Absolutely.
But, you know, one of the things, I've been a physician for a long time, more than I can remember. And one of my queries, especially with the type of population we deal with, is how do we see the role of prevention, you know, and the impact that can have financially in the healthcare of the state? You know, because I would think that probably if we really support a lot of prevention, active prevention, you know, especially in infectious diseases, and we can enter nutrition or other areas too, that can really cut those costs, you know, in treatment, you know, and benefit to all of us. You know, and I think that education in that regard to the patients and especially to all of us, healthcare workers, you know, is that we need to talk more to our patients about how to avoid risky behaviors or things like that.
Totally agree with you. There was an article written by McKinsey about 8 or 9 years ago, and they said the 3 imperatives to control healthcare cost. And the imperatives were to eliminate administrative overhead. Dr. D'Agostino, you know that. Price transparency, which we are no way close to right now. And lastly, to eliminate the burden of chronic disease. Now, a student asked before you came in, somewhere right in there, about what about needle exchange programs? I'll point out that Governor Mike Pence, Vice President Mike Pence, when the governor of Indiana instituted a needle exchange program because there was an outbreak of hepatitis C, people sharing needles, put in a needle exchange program hoping to prevent, with a nickel syringe, the expense of treating an acute hepatitis C or an HIV case. So obviously we have an obesity epidemic, which is driving our problems of the metabolic syndrome, hypertension, heart failure, renal disease, etc. Cigarette smoking, which we've made great strides in. If we can eliminate cigarette smoking, that'll be a profound impact both upon the health of the individual, but also upon cost to society. So I would agree with you, preventive services must be emphasized, and unless we address it, we can never catch up with the expense. We must address the preventive services. Yes, sir. Thank you. Anyone else? Yes, sir.
So I was intrigued by your model. I didn't hear in it what would be the effect on new cases if you eliminate the virus from those patients, and they may not have as many new cases. Was that in the model as well?
So the question is, what about new cases? Fortunately, although the incidence of acute hepatitis C is climbing, it's a still relatively low level. But clearly, if we eliminate the reservoir of hepatitis C, then we are less likely to have new cases. We didn't put that in the model because really, if you talk about, although the number of new cases is 100% more than last year, it's such a low number that 100% is not that big. But it's still there. And our hope is that there would be a herd, not immunity, but a herd protection by eliminating that reservoir. So there's a lot of stuff. For example, we didn't model the benefit of having somebody at work earning taxes, earning a paycheck and paying taxes, as opposed to being on disability, sucking up federal support programs. And so we actually think our model is more robust than even we modeled it. But at some point, you need a true economist, and that's another level of expertise. But yes, very great point. Yes, ma'am.
I've got two questions. The first, a joke, the second, not. The first, are there going to be questions for this lunch round?
He said yes. Yeah.
And second, I feel like no matter what your political beliefs, like as future positions, we're all going to be coming into the current state of healthcare in the United States. And I can imagine for all of us who are so interested in healing and taking care of our patients, what's the best way to stay educated about politics and healthcare while still helping our patients as much as we can?
Well, you're going to be, as you go through your next 2 years, ideally, some of you, if not many of you, would have a chance to do an internship with us. But practically speaking, you are in this incredible period of your life where intellectually you're just growing, and your sense of responsibility is growing. And by the time you come out of your internship and residency, you will have been somewhat transformed. Your character, hopefully, remains the same, of high sterling character, but your intellect and your ability to use and process knowledge will have been increased. And that's almost a pressure cooker. Practically speaking, it will probably be my personal experience, it is difficult for someone going through that process to kind of maintain a wide range of other interests. But once you come out, absolutely. Now, that is not to say that you can't be an advocate. You absolutely can be an advocate, and you can absolutely follow, but it's going to be more kind of you make the conscious decision as opposed to it's just something you can do as you pass along. As you move along in life, I think the biggest challenge is not to be caught up in the cable TV channel of your choice, but to try and go beyond that. Not that there's not good information there, but to go beyond it. Because going beyond is where you move beyond that which just people tell you and that which is an analysis which you can actually bring to the table. And that will, again, take somewhat of a conscious effort, but with the intellectual training that you have, you should be able to do that pretty easily. And I say that not to flatter, but just to complement the process that you are in and to observe that that is what I've seen from talented young folks like you as you move on to, as someone said to me, to look distinguished. Distinguished means you have gray hair. Yes, sir.
On the model and for the hepatitis C acquisition, what is like the avenue of finance, and has this been done before? You know, and is it through the insurance company that the finance is going through, or is it an extra cost to the patient?
Yeah, so this has never been done before. We're actively engaged in this. Again, that intern that came to help us put together the spreadsheet, this was first. We don't know if we can pull it off. I won't name the drug company, but we are meeting with the drug company. That sooner or later we'd have to put it out to public bid. You can't just give it. But we're sticking mainly with Medicaid, the Medicaid population, because that's the one in which the state, it's harder for Blue Cross. Frankly, statistically, someone on Medicaid is most likely going to live and die in Louisiana, whereas people with private insurance may get transferred by their company from one state to another. And so it's easier for the state to say, this is our population, we're going to have these folks. It behooves us to treat them if we're going to save long-term cost. And so there's kind of a rationale behind approaching it from a Medicaid perspective. Yes, ma'am.
So, as far as eligibility criteria, in class we learned that hepatitis C is kind of like having two peaks in the older population and people in their 20s in response to the opioid epidemic and heroin use. How would you determine if it is cost effective to treat someone that's 20 that is dealing with addiction, if they could just be cured and then relapse? Is there any sort of, is that being, factored into the criteria to make sure that they are no longer using and no longer at risk of just contracting it again from sharing needles?
That's a great question, but 95% of those who are currently infected would probably be 45 plus, okay, 40 plus. They either got hepatitis C when they had a blood transfusion when they delivered their child before the blood was cleaned up, and or they went through their use of high-risk behavior in the 60s and 70s and 80s. There is another generation coming along. This model, if you will, is more for the bulk of the patients who are older. But we would have to address the younger as well, because the question regarding herd protection, if you will, not herd immunity, but herd protection, would center around trying to eliminate reservoir of disease. But if someone's going to relapse, what have you done? And so there's an interplay there which we don't attempt to address. We would frankly bring in the public health folks to try and further refine the model. I think I have time for one more question. Anyone else? Hey, Paul. Nice to see you. Anyone else? Yes, ma'am. Last question.
So coming back to what you mentioned about prevention, it seems like the current administration is pushing back against some of the preventive services now, like Planned Parenthood, for instance. How is that being addressed?
You know, Planned Parenthood, I've always chuckled a little bit about Planned Parenthood. I don't think they're pushing back. In fact, they're absolutely not pushing back against the idea of prevention. I chuckle because Louisiana has 2 Planned Parenthoods. One's in Baton Rouge and one is in New Orleans. 2 of the areas of the state most overserved by OBGYNs. We don't have one in Union Parish, Bienville Parish, Catahoula Parish, Webster Parish, and I could go down the list. So there's been a real, just to speak honestly, let's just put the facts on the table. We got 2 facilities that all are about prevention, but they're in the 2 areas of the state that there's no way a woman in Union Parish is going to take a bus down there for her pap smear. Wouldn't we be better off taking the dollars for those 2 institutions in 2 areas which are overserved by physicians, if you just look at the manpower, womanpower, and taking those dollars and putting it in the public health unit in Union Parish and Bienville Parish and Catahoula Parish? Of course we would. Health care closer to where the patient is, particularly the lower income patient, is the health care which is most likely to be accessed and which is most likely going to give us the benefits of those preventive services. So the administration budget, frankly, has things I strongly disagree with. Taking money away from coastal restoration in Louisiana. You might guess, going to strongly disagree. I'm going to support more dollars for the National Institute of Health, National Science Foundation, and CDC, because I see their value. But that's one which is a little bit of a red herring. That if there's a really good PR team making that argument, but if you think it through and you think about Grant Parish and it's being underserved, that's it. Now this woman in the black dress is yanking me. But by the way, let me say once more, she started off as an intern in somebody else's office, and now at age 25 or something, she's the one who tells me what to do. And so you quickly have a lot of responsibility should you wish to go there. I thank you so much for your commitment to our society. For you who are starting and for y'all. If ever I can assist you in that commitment, let me know.